Dr. Javier?
All right, thank you very much. This is going to be a very easy talk, and this is going to be basically of my experience. I'm not going to inundate you with data and trials of comparative procedures. Those of you that are doing veins, basically most of the experts on this, and been going to vein conference for the last 12 years, and we all have a same approach to venous disease. Basically, this is what you see on a patient with complaining of venous symptoms, dilated great saphenous vein or a 5 millimeter, who shows pathologic reflux over 0.5 seconds. This is a very straight great saphenous vein. So many of you that are doing veins would choose radiofrequency or laser. Actually, my decision to choose either of laser or radiofrequency, I do it on an individual basis. Both techniques are very good. Head-to-head comparisons have shown very similar results. So when I use radiofrequency, usually as a patient with a straight vein, I like to do it in slim patients. They have very thin-skinned. I prefer radiofrequency over laser. Also, if the exit point of the GSV is not too far below, and patients that are looking for aesthetic, I tend to choose radiofrequency over laser. And there are two devices approved in the United States: the closure fast from Medtronic, former Covidien, and now the new vein close RF, which use a similar technique. The only difference is that the vein close has a catheter that allows you to deliver either 10 centimeters of radiofrequency or 2.5 centimeter radiofrequency. And it's a pretty nice device that really speeds up the procedure, and it gives you a lot of flexibility when you're treating long veins. Regarding when I choose laser, I tend to choose laser for very large diameter veins. That way I can increase the joules. Some of the other experts, what they do is they actually deliver two treatments using the radiofrequency. I prefer to use the laser. I also use it on veins that have recanalized, and I can introduce a catheter. On short segments of 10 centimeters, I prefer to use the laser. And also on self-paying patients that come in, the laser fibers are a lot less expensive than the radiofrequency, so I offer them the laser therapy. And certainly laser is a lot less expensive than RF MOCA and even the PEM or cyanoacrylate. This patient has a large perforator. The radiofrequency, the only device approved for treatment of perforator is actually the stylette from Medtronic. And basically use it similar to how you do the radiofrequency for GSV, introduce it on the perforator and treat it. This patient presented with left great saphenous vein reflux with axial reflux, dilated over 5 millimeter, and this one extended to below the knee. And we chose cyanoacrylate on him because he wanted to use it. He didn't want to have needles down on him. This procedure has a very high patient satisfaction. You don't need to mess him for it, and no compression stocking, and the patients can return to daily activity immediately. I only use it on self-pay patient because it's not covered by insurance, and it is a very expensive procedure. So we do offer it to the patients and those that don't want to go be exposed to the tumescence. It's delivered under ultrasound. You can see longitudinal view here, the catheters, and they have this coaxial characteristic under ultrasound on the short axis. We did the animal study and also did the feasibility study. We just published our 3-year results. And also you saw the 2 years result of the E-close and the V-close. And actually at 3 years, we still have over 90% closure of the GSV. And this is the final result. You can see that it's very similar to when you treat patients with ablation, the closed GSV with good flow in the trunk and in the common femoral. So this is patient how he looked before the procedure, and this is how he looked after the procedure. This patient presented with pain in her right leg and had a very lengthy GSV, dilated over 8 millimeter and extending to below the mid-calf. And she had reflux over 1 second. On her, we chose a Clarivein because it was a long, straight, great saphenous vein below the knee. And when you get to that region, it's better to use a device that will avoid injury to the nerve. Nice thing about this also is that you don't use tumescent, so you're going to avoid the needle sticks if patients ate so much. You don't need to buy a generator. The catheters are expensive for private practice. You did get the same RVU for the others when you are in a hospital setting, but for practice, it certainly is not as cost effective and not good for tortuous vessel. And recently they just had their CPT co-assigned. So the patient had a combined MOCA with phlebectomy, and as you can see, this is a very easy procedure to perform. You have very minimal downtime, and the patients do very well. These are some of the challenging cases that you're going to find. That a patient had neovascularization of both bilateral great saphenous vein with significant amount of lipodermatosclerosis, and we did the ultrasound on her. She has significant amount of reflux, and you can see all these vessels here. So the plan for this lady was ultrasound-guided sclerotherapy of both great saphenous vein, and then I brought her back at 3 months. And if you look at the study, they recommend that after you do the treatment to actually, if you don't do the phlebectomy immediately, to wait 3 months to see the results before you do the phlebectomy. I tend to do my phlebectomy immediately, but in this lady, we chose to wait for a better response due to the amount of skin problems that she had. So sclerotherapy has its advantages and disadvantages. Actually, it's inexpensive, easy to do in deep sites, tortuous vein. Actually, like what Ron Bush says, that you give him a needle and a sclerosant, and he'll treat veins wherever they are. However, it has a problem that it's staining and recurrence and causes tender lumps. Sclerotherapy uses perforators that are too deep for ligation, tortuous vein, those with neovascularization, and then pelvic escape. There's only one sclerosant approved for foam sclerotherapy, and that's varithema. It uses highly concentrated CO2 and O2. It does not have a CPT code yet. However, it is a very expensive sclerosant, averages about $70 per cc, and you tend to use 10 to 12 cc per cases. Ultrasound-guided sclerotherapy. This is just part of my video here, but this is one of the ones that I can pull with my Mac. You can see here I'm introducing the needle. What you want to do is you want to elevate the legs of these patients and empty the veins so you don't have any blood in it, and that way you get better contact of the sclerosant. You inject the sclerosant, and then you get the result of it. Ambulatory phlebectomy is a must in any vein practice that you have. It's very easy to perform. It actually helps to low recurrence, high patient satisfaction, and minimal scarring. It's actually, patients feel very well when they don't see the bulges there. However, it's limited to superficial segments, scar, and nerve injury. These are the tools that I have for phlebectomy. I like to use the vascular solution. We created this device, but I don't have any disclosure here that we don't have any royalty on it. But I really like it because it has the stab on one side and the hook on the other, and you don't have to be changing from one procedure to the other. Basically, you puncture this little orange while you're pressing down, and it gets a blade out. It produces a stab, and then you just, with a hook on this side, you just start doing your phlebectomy. There's a patient with a superficial perforator, very close to the surface. As you can see here, on these patients, you can do a ligation, very easy to do, and very good results. It's easy and superficial, and it has a code of 33761, but it's very hard to do on deep perforators. So in summary, venous anatomy is very complex and diverse. You must know different types of techniques. You must have multiple tools. One is not better than the other. I think they just complement each other, and be familiar with the anatomy and the source of reflux. Thank you very much.